I would like to thank again everybody connected via YouTube. We have around 400 average connections, and there has been a lot of discussion on chat. I was following the YouTube chat, and I will try to take some of the questions from YouTube and forward them to the speaker. I will try that. I don't know if I can manage everything, but okay. We can move to the next talk, which is by Francesco Casella for Politecnico di Milano.
Thank you, Fabrizio. Can you hear me?
Yes, and please, good. Francesco, go.
Thank you. So let me first start thanking Fabrizio for organizing this very nice event and for inviting me to present my work here. As Thomas Paghesini appropriately said about an hour ago, we are not epidemiologists. So the first question is, why on earth did I ever get into this topic, which is completely new to me? And yeah, that before I get into answering this question, this is the outline of my presentation, so you know more or less what is going to happen. So why did I get into this in the first place? Let me briefly show you the timeline of events that affected the entire planet and myself for what it matters. As you all know, at the end of 2019, the COVID epidemic started in China. On January 23rd, a very harsh lockdown was declared in Wuhan, and on the following day on other cities nearby that. And the thing was a Chinese thing by that date. On February the 21st, the first officially reported case in Italy was declared in Codogno. On the next day, it was Saturday, all schools closed in Cremona, that's where I live, 30 kilometers from the epicenter of the outbreak. And this really caught us by surprise. On the next Wednesday, my mother was taken to hospital with very severe bilateral pneumonia. Still not clear what she had at that date. And after a couple of days, I was quarantined until March 16 because I had visited her on Monday the 2nd or something like that. On the next week, national lockdown was ordered in Italy by Prime Minister Conte, effective March 11. On March 12, I attended a press conference by Boris Johnson and his scientific advisor, Sir Patrick Vallance, announcing herd immunity plan for the UK, and I was really shocked. You should look that on YouTube. It's unbelievable. And on the following day, my mother's COVID test returned positive. That was 9 days after she got into hospital with terrible pneumonia. That one of my friends who works in the hospital told me, look, this is COVID-19. You don't need a swab test to understand that. So you understand I was hit quite hard, and that made me think a lot. Particularly two things hit me as a control engineer. I saw exponentially growing reported cases, death cases, everything was growing exponentially with doubling times around 3-4 days everywhere, particularly in Italy, but not only there. And then my mother's case, which was not an exception, it was the norm in Lombardy, more than 1 week, made me understand that there's a huge measurement delay. And when I put 2 and 2 makes 4, strongly and fast unstable dynamics and delay means maybe control is problematic. So I thought a bit about it. And I tried to answer these questions. Can this process actually be controlled at all based on reported swab test results? And can we use control methods to answer this question? So what I did mainly aims to trying to give an answer to this question. So I first did some modeling, and the modeling is aimed at answering those questions and not to make long-term predictions or anything like that. After a few trial and errors, I ended up with a SEIR model. The exposed part I added recently, and it turned out it was essential in order to capture the short-term dynamic behavior, which is what mostly is interesting for feedback. I'll get back to that in a minute. probably already know this model. We have 4 categories of people. There's a first flow of people getting infectious. That depends on this parameter beta and on the number of infectious and susceptible people, as well as on the total population N. People getting infected become exposed, but they're still not infectious. They become infection with a certain rate. This epsilon is the inverse of the average incubation time, which is 6 days. And then infectious people eventually recover or die, which from the point of view of expanding the disease is the same. A recovered or a dead person cannot further spread the contagion. We need some extra variables here and some assumptions which are essential for the further development. So we have the number of infectious subjects, I, at time t. We know well that a lot of people is not tested either because they do not have any symptoms, but yet they are known to be contagious, or because they don't have severe symptoms, so they don't show up at hospitals and they simply don't get tested because there's not enough swab tests for everybody. So there is a ratio between eventually tested infectious subjects and actual infectious subjects, which is still largely unknown. It could be 0.1, so 1 test for every 10 infectious people, or 5, we still don't know. There is also another crucial parameter, which is the ratio between actually positive tested people and people needing intensive care unit to avoid dying from severe acute respiratory disease. And that I estimated about 4% in Italy. Numbers can vary a bit from this number. The last very important number is the number of intensive care unit beds, which is about 1 bed for 10,000 people in Italy. Germany has 3 times that, I guess. UK has less than that, but the order of magnitude is approximately 1, let's say 10 to the minus 4 compared to the general population. Now, I think we all know what happens if you have a severe acute respiratory distress and you cannot be put on a ventilator. You die by suffocation, possibly under morphine if there is some chance of getting that. Otherwise, it's really a bad death. We don't really want that to happen. No policy should come up to a point where people are refused getting an ICU bed if necessary. So the basic assumption for any control policy is that ICU beds should never be in short supply. This translates into this inequality, which means that the acceptable number of infectious people can be a very small fraction of the total population. Maybe not 5%, it could be 2, it could be 6, it depends on these parameters, but it's anyway a small fraction. And also, given the time scale of these dynamics, this will also mean that if we keep this limit for a few months into the outbreak, the number of infectious people, of exposed people, and of recovered people is very small compared to the total population, which we assume is susceptible a priori because of the precautionary principle. So this allows us to simplify things a lot, because if S is approximately equal to N, then we can cancel out these terms. And then the first equation gets completely decoupled. The last equation, we don't really care. The most important 2 equations to describe the system are the ones that you see here. They describe the evolution of the exposed and infectious people. And also we need to remember that the actual positive tested infectious people are only a fraction alpha of the actual infectious people. That's the core of the model that we need to analyze the controllability of the system. Now, we can use this model to figure out what is the free motion before lockdown. This is more or less the same that Beppe Carafiore tried to do, if I understand it correctly. So we start from this model. We assume that there are no social restrictions, so the infectiousness parameter beta is constant and is equal to some beta 0. We know that R0 is greater than 1. There are different estimates for this, 2.5, 3, 4. I even read 5.6 in China in one recently published paper. Anyway, this beta 0 is way larger than gamma, which is the rate of recovery if there are no social restrictions. So assuming that those parameters are constant, the eigenvalues of this simple linear system are the solutions of this equation. And it turns out with beta 0 greater than gamma, you have one stable solution, one stable eigenvalue, and one unstable eigenvalue, which we call R. So basically, after the epidemics, and this stable eigenvalue is quite fast. It has a time constant of a few days. So after a few days into the outbreak, the stable mode dies out, and what is left is the motion of the unstable mode, which means everything is exponential. The infectious people are growing exponentially, the exposed people are growing exponentially with this ratio, and also the the people that will eventually get tested positive are growing exponentially because they are proportional to the infectious people. This is quite scary, and that's what was actually observed. Now, let's try to make this a control-oriented model in general. So now I am putting the explicit dependency on time. The first two equations are the ones that we saw. I'm adding one more equation with subscript R, which stands for reported. This is what motivated me starting from my mother's case. Even though some people will eventually get tested positive, they are actually reported as positive after some time delay, which was 9 days in the case of my mother. So this is this tau m parameter. In fact, this tau m is more than that, is the time to actually get the result of a swab test plus the time tau t between the instant one becomes infectious and the instance when the decision is taken to actually test him, which currently is only done in two cases. Either you have very severe symptoms, or you are proven without doubt to have had contact with somebody else who's been confirmed after maybe 9 days. So there's a lot of delay here as well. Now, this beta, the parameter beta, turns out, in case you want to study public health policies, to be related to a control parameter, the control variable, as Thomas said in his very nice talk. The way I model this is in two stages. I have this function, beta of u, which is the effect of social restrictions u on the contagion rate. And then the intensity of social restrictions prescribed by the government is this u of t. This could be meant in terms of, say, I only close schools, or I close schools and barbershops, or maybe I prohibit large gatherings. Each of these interventions has an influence on this parameter u. Or maybe I think the intuition is very good. This u of t could be modulated by using some kind of a PWM strategy, as Thomas proposed with his co-workers. Now, the problem is there's a lot of uncertainty in this beta of u. There was this nice report published by the COVID group at Imperial College. This is the estimated reduction of the relative reproduction number in 11 European countries due to different types of policy, with 95% confidence intervals. Now, RT is beta over gamma. So if gamma, which is the recovery ratio, is more or less constant, assuming we still don't have a cure that can change that, then a reduction of RT is the same as a reduction of beta in relative terms. And you see here that this nice work that was done using Bayesian inference on statistically available data gives us some estimates for the effect of different social measures, but the confidence intervals are huge. They are really huge. Like lockdown is 50%, but the 95% confidence goes from almost nothing to almost 80%. And that holds for everything. And this is inherent in the process of collecting statistical data, because what does a lockdown mean? In Italy, it meant something. In Austria, it meant something else. In Germany, it meant something else. And if you want to have a large database, you have to put this stuff together. So, of course, you get a large, let's say, spread and very large confidence intervals. So let's remind that beta of u has a lot of uncertainty. Now, I did a validation of this model in two cases. The first is the Chinese outbreak. The numbers you find here are taken from a paper published on the Journal of the American Medical Association, rather some time ago, 24 February, if I'm not mistaken. What you see here is epsilon ER. So that's the daily number of the daily rate of new reported infectious people. You see the parameters identified here manually. I didn't use any fancy least squares, only manual trial and error. By the way, this value of epsilon, which I identified from data, is the inverse of 6 days, which happens to be the mean consensus for the incubation time, which is good. What you see here is an exponential trajectory. First, lockdown was applied on day 5th, which was January 23rd in Wuhan, and on the following day on 15 other major cities in the neighborhood. And you see there is basically no effect for 11 days. The exponential continues growing. What you get after that is primarily governed by the dynamics of the exposed compartment. In a first version of this model that you may have seen on Archive, I was just using the SIR model, but that predicted a very sharp drop of these new cases, which was not right. The right way to get this short-term behavior is to actually include the E compartment. That's what I found. And also here, you see that you can fit this behavior by assuming a reduction of beta after lockdown, which was very consistent, minus 84%. By the way, just for the sake of it, I tried to run this model until the end of the epidemics, and it gave me a total amount of 110,000 cases, which is not too different from the 83,000 cases officially reported. But that's not the primary reason I'm doing this model. Then I made another validation on the Lazio outbreak. I picked Lazio from Italy because the situation in Italy is very heterogeneous. Lazio is nice because basically before the first decreto of 11 March, there was basically no social restriction. So there was a first decree applied on 11 March, this first round of measures, closing schools and other things. And the second round followed on the 25 March, where also most non-essential working activities were stopped. As you can see, there is, again, a delay, which is estimated in 16 days. You see a first corner here. This is when the effect of the first round of measures becomes apparent. And if in the model, if you don't change beta, you would continue on this exponential trajectory. The data here is taken from the Dipartimento della Protezione Civile. They have a nice GitHub repository, and the data was collected by my colleague Paolo Mantegazza of Politecnico. I thank him for the effort. Then the second round of interventions took place after a couple of weeks on the 25th. And again, here you see this corner. Without the second intervention, we would be on this second trajectory. By the way, notice that the number of infectious people, this is different. This was a kind of derivative. This is the new number of new daily reported cases. This is the total number of reported infectious people. You see, this is growing linearly, which means the number of new cases is more or less constant, which also means that the measures that we currently have in Rome are not enough to bring R0 below 1. But that's another story. So once I had this model, I tried to apply some control analysis to it. And I can briefly describe two possible control strategies. One is suppression. This is very easy to explain. Basically, the policy is until the number of reported people is below a certain scary threshold, IS, you don't do anything, you being government. And when the number becomes large enough, you apply fairly strict measures, U-bar, so that you hope that the parameter R, which is the difference, which is related to the difference between these two things, will become negative, sorry, so that will mean the epidemics starts decaying. In fact, what happens is that the number of exposed individuals starts decreasing immediately, but the number of infectious individuals starts decreasing only once the pool of previously exposed people has gotten ill. And this takes 1 over epsilon days on average. And then you observed everything after 1 or 2 weeks because of the delays. So eventually, the number of tested infectious people will peak, and will have a peak which is m times larger than the number that you use when selecting this threshold. So when you have, say, 10,000 reported cases, which was the case in Italy, you get scared and you say, okay, lock down everything. And then the 10,000 cases become 100,000, 10 times bigger. This m can be computed by solving the model. It was 10 for the Chinese outbreak, And it can actually be much larger if the delay is increased and if this number here is not small enough. The most important thing is that once you compute this M, you have a simple criterion. It's of course based on highly uncertain data, but it's simple to understand. You have to pick a threshold for this scary number according to this relationship in order to avoid the ICU crisis. And if M is very large, you need to act very early. You remember sigma is about 0.04 for Italy, and M is probably about 10. So this factor is 0.5. It means you should be really scared when you have a number of reported cases which is twice as many as the ICU beds, which was in fact what happened in Italy, which barely made it with ICU beds. That's one possibility. Of course, when you have suppressed the epidemics, the question is what do you do next? The other possible strategy is mitigation. So if you want to apply mitigations, there are basically three objectives. Ride through the epidemic as fast as possible, avoid the ICU crisis, and eventually achieve herd immunity as long as there is such a thing. We're still not certain. So how can this be modeled in mathematical terms? First, you compute an optimal policy, U0. Remember, this is, let's say, the amount and timing of public policy with the most sophisticated models available, trying to respect the constraints of ICU bed availability at all times. The problem is during, while R0 is bigger than 1, which has to be at the beginning because you really want the numbers to increase at the beginning, these optimal trajectories are unstable. So you simply can't apply them in open loop. You need to add some feedback corrections. And the only way you can apply feedback is to base the feedback on reports of swab tests. For the time being, there are no other mechanisms. You may use deaths, but this is even more delayed, so that won't be a good idea. So I tried to put forward a very idealized settings, and then I can anticipate to you that even if the idealized setting doesn't work. So I assume that I know all parameters, and then I design a linear feedback controller, C of S, so that I can apply these interventions U, which are the, let's say, open-looped plan ones, plus a corrective term. And here I add some gain scheduling to make sure that I get a more or less constant feedback loop transfer function. By the way, here there is an additional delay tau c, which takes into account the fact that government needs time to actually collect the data and take decisions and communicate those effectively to the public. Maybe 1 or 2 days, it depends. These days, it's very easy to communicate things to people with Facebook, but if you want to lock down people, you have to actually write down a decree and make it effective. This also takes some time. So at the end of the day, this very idealized feedback policy has a linearized closed-loop transfer function, which we pick at some time TA during the trajectory, which is characterized by a stable pole P, an unstable pole R, and some substantial measurement and decision delay. And this should ring a bell to you. If we have an unstable pole and measurement delay, control may be problematic. In fact, there is a very nice result in a paper by Carlo Anostrom on European Journal of Control, so it's EJC here. First and foremost, this mu here takes into account the effect of uncertainty on the gain scheduling. So if everything is known perfectly, mu is 1. But as soon as there is some uncertainty, mu could be 1.5 or 0.7. And we already saw data that tells us there is indeed a lot of uncertainty there. So we need some robustness. And there is a nice result by Carlioan that says that if we want a modicum of robustness, like having the infinity norm of the sensitivity function to be less than 2, there is a constraint that with the symbols I'm using in this paper can be translated into this condition. So there's a total time delay, which is the effect of the time delay from what you get infected from to when you get a swab test, plus the time to get the swab test processed and reported, plus the time required to take decisions by the government. While TD is the doubling time corresponding to the unstable pole. And this ratio has to be less than 0.2, more or less. Now, if you take the data with the Chinese outbreak, you get 3. Okay, that's 15 times bigger than the limit put forward by Caglione. And if you take the data from Lazio, T over TD is 5. That is like 20 times bigger. So, I mean, of course, this is a very, and this is an idealized situation. We know everything, and we designed very carefully a robust gain-scheduled linear control. So my interim conclusion here is that at least during the initial exponential phase, reliable and robust feedback control is utterly hopeless. No chance, really no chance. And that's maybe one of my first conclusions. I would like to mention this figure that I took from a famous paper taken from Gunther Stein's body lecture, Respect the Unstable. This is what happens when you fool around with unstable dynamics. The green curve is the reading of the neutron flux in the Chernobyl plant when they eventually got lost control of it. In that case, these fast dynamics had a pole of 2 seconds to the -1. Now we're talking about days to the -1, but this is scary and deadly, more or less the same way. So let me just put the thing in perspective. Of course, nonlinear controllers may achieve somewhat higher or better performance, but will sure enough suffer from a combination of uncertainty, instability, and delay. There's nothing we can do about that. The process is ill-conceived. It's not really meant to be controlled. We may try to achieve this condition that I mentioned, on one hand, by trying to reduce the reporting times as much as possible to just a few hours, have instant testing, and also by testing very aggressively a large and periodically a large representative swath of the population without waiting them to show severe symptoms. This way, we could reduce this tau substantially. The other strategy, so notice that here, I'm not trying to design a better controller. What I'm trying to do is to improve the dynamics of the process so that it can be controlled more easily. That's the key point. Another possible strategy is to employ this mitigation only, not at the beginning of the outbreak, where the doubling time is very short, but only on very cautious reference trajectories that have a value of beta which is much less than beta 0, and correspondingly a doubling time which is not 4 days, but maybe 12 days or 15 days. However, applying the first strategy requires availability of a first-class testing infrastructure, maybe like Germany. This cannot be improvised. There's no way that an app will miraculously solve this problem. And the second strategy may be achieved, but it can be very dangerous because this beta may also change due to unforeseen disturbances. And just to give a concluding remark on this possible issue, we can learn something from Singapore. Singapore is very close to China. They applied a very effective long-term mitigation strategy using high-tech solution, lots of swab testings, apps, thermometers, you name it. And they managed to keep, to mitigate without any lockdown. They managed to mitigate the outbreak effectively for many months until the beginning of March. Then something happened, and in retrospect, this something was an outbreak in migrant worker dormitories. I'm not going to talk about the political situation in Singapore, but I think you understand perfectly well what this means. So numbers start growing exponentially, and the government got scared, as in the playbook, and they applied the full lockdown on April the 7th. And this is the figure I got yesterday. It's data from the Singapore Ministry of Health. The lockdown was applied when they had about 1,000 cases, and now they have 10,000 cases. So this factor M is sure enough bigger than 10. We still don't know where the peak will be. The delay is at least 14 days. Maybe this is starting to stop being exponential, but we still don't know. And the doubling time is, again, 4 days, even though the regular Singaporean people are using all their apps and all their gizmos. It's just a few 100,000 migrant workers, which are essential for their economy, which are breaking down the whole thing. And mind you, we have the same situation. We do have migrant workers picking up fruit and stuff like that. So I think this is a lesson that really is really stark and needs to be very well understood. Let me get to my conclusions. I hope I'm not too late. So COVID is particularly dangerous because it's very contagious, and we have contagions from asymptomatic subjects, which is a big deal. The process dynamics features unstable behavior, large uncertainty, and large both measurement and actuation delays. The conclusions that I got from these models and very basic control theory are that suppression strategies can work if they are adopted early, based on appropriate modeling, not just on being scared on part of the government. Mitigation strategies cannot work unless testing time is drastically reduced and the reference trajectory is kept at low beta, that is to say with RT close to 1 or R0. These are more or less the same in this context. However, even apparently successful mitigation strategies can easily run away and become uncontrollable due to unforeseen disturbances, so we have to be very careful about that. I would summarize this with this phrase, which I find very appropriate: respect the unstable. And I would like to conclude with a dedication of this work to my mother and my mentor, Professor Maffezzoni, who I think played a major role in getting this thing done. Thank you for your attention.
So thank you very much. Thank you. Thank you, Francesco. Okay, I've been muted. Okay, I'm fighting with mute. It is really interesting. I have to say that Francesco's work, Giuseppe's work, Thomas' work were those who motivated me to do this seminar, and then I discovered that there were many more people working on that. But I think this is the paper that we saw now is the kind of message that we would like to convey to the decision makers. So we have time for a very quick question, if we have one, because...
Yes, we have a question from Patrizio Colaneri.
Yes. Patrizio, I just ask you to be concise.
Okay. Yes, I will be concise because can you hear
yes.
me?
Yes.
Okay. Because I mean we have already spoken on these things many times during these months, so I knew already your work and so on. So my question is very simple. Did you try to include also the dynamics of susceptibles in your model to see what the, let's say, I mean, because in principle, these dynamics could help in understanding what control can do, because the number of susceptible decreases, then the real important factor is R0 times S. And so, I mean, this can help the control, of course, because, I mean, it's still unstable, but still a certain amount of S, but I mean, then it becomes stable in some sense. And so, I understand that is a non-linear term, so, I mean, maybe, but I mean, at least a linearization around different points of S, see how the...
let me try to elaborate on that. I think the reason why I did not do that, and mind you, this work is mostly focused on the initial phase of the outbreak. And the motivation was that I got scared when the thing was starting. So maybe it's not really appropriate for, let's say, long-term studies if we possibly wanted to achieve herd immunity, which is what you have been hinting at. This is deliberately excluded. My point is that this constraint here makes reaching herd immunity a very, very long deal. The maximum number of infectious people that you can allow at any point in time, for example, in Italy, is something about around 100,000 people in order not to get ICU beds overwhelmed. And basically, it takes people, let's say, a couple of weeks to recover. So every 2 weeks, you can process 100,000 people. How many weeks do you need to get 60 million people processed? It's 600 weeks, right? That's like 50 years. It doesn't work. So I think this constraint, unless there is a major breakthrough in medical interventions that make this pneumonia substantially less deadly than it is, there's no chance because this limit is going to I mean, you're trying to empty the sea with a tablespoon, and since this number is very small, then basically this number S doesn't really change. There are wild speculations currently in Italy so as to how many people were actually infected. And the wildest speculations say maybe 10 to 15%, possibly in Lombardy, which was very hard hit, most definitely not in southern Italy. It's been a hell of a mess, and if we've been lucky, we may have immunized 10% of the population. In order to get herd immunity, as long as that such a thing exists, we would have to get another 60 or 70, which means going through this another 6 times. Do you see the point? I hope so.
Yeah.
Okay. Of course, this is based on the current situation.
Yeah.
If we discover that the virus is becoming less deadly, or if we have some effective cure for the COVID pneumonia, or if we see that serum can help recover patients, then of course the situation is changing completely.
Hopefully. Hopefully. So thank you very much again.
Thank you.
Okay, we have